Now, a lot of these pharmacologic targets we've talked about in very great detail in the RAS video, so I'm going to go a little bit faster through these. If you want a more detailed explanation, go back, check that video out. But ACE inhibitors, again, lisinopril, captopril, and enalapril, these are going to cause decreased levels of angiotensin II, which is very, very helpful in heart failure, right? Because again, if you just remember who's the bad guys and who's the good guys, right? The bad guys are going to be renin, angiotensin II, aldosterone, and sympathetics like norepinephrine. Okay, those are the bad guys. And the good guys are going to be ANP and BNP. So if you know who's on the good side, who's the heroes, and who are the villains, I think you can kind of figure this out. So again, the red are our villains, the green are the heroes. ACE inhibitors, right? Angiotensin II levels are going to come down because I'm inhibiting the conversion of angiotensin I to angiotensin II. That is going to be a good thing, right? That's a very good thing because I have less angiotensin II to cause vasoconstriction, causing increases in afterload and stimulating the RAS system. By inhibiting angiotensin II, you'll also get some inhibition of aldosterone as well. And remember your classic adverse effects here: dry cough, hyperkalemia, and angioedema. And again, we talked all about this in the RAS video, so check that out. Angiotensin receptor blockers, sometimes used as opposed to using ACE inhibitors if the patient is suffering from, some of these side effects that we talked about here. So the way that I want you to kind of think about these diuretics, so we're just going to say that this is my glomerulus and my proximal convoluted tubule. I kind of have my loop of Henle here, distal convoluted tubule, and then let's just say that this is my collecting duct. So collecting duct, DCT, distal convoluted tubule, proximal convoluted tubule, loop of Henle. Okay, and we'll talk about all of this, more in the renal section, but I do want you to just have a visualization of this. These mineralocorticoid receptor antagonists are essentially going to be blocking aldosterone binding here at the collecting duct. And remember, what aldosterone is doing here at the collecting duct is it's trying to bind so that we can increase sodium reabsorption. It wants sodium to come back into the blood. We don't want that, right? We don't want more sodium coming into the blood because then we have more fluid. We're already fluid overloaded. We want to inhibit that. So that's what these mineralocorticoid antagonists are doing. So they're acting here at the collecting duct to accomplish that and decrease aldosterone function, essentially. Now, one thing to really keep in mind here is when aldosterone acts, right? Aldosterone is normally going to increase sodium reabsorption, right? And it's going to cause an increase in potassium excretion. So your blood levels, if I look at the blood, right, my sodium levels in the blood should go up, right? But my levels of potassium in the blood should go down as a result of high levels of aldosterone. So that's why patients that have heart failure will frequently have hypokalemia. They'll have low potassium for that reason, because there's so much aldosterone being released, it's causing some of that potassium to get excreted. Now, if I use a mineralocorticoid receptor antagonist, this should block these receptors, and it could lead to, if I gave the patient too much, it could cause hyperkalemia, right? It could cause hyperkalemia because I block too many of these receptors, aldosterone's not binding, and I'm actually retaining more potassium and excreting more sodium. Okay, so it can cause hyperkalemia for that reason. That's important to remember. And also, look, some of these other drugs that I'll also be giving in heart failure can also cause hyperkalemia. So again, that's why when we're talking about a heart failure patient, there's always three things you're looking at. You're looking at an elevated BNP, see if they're in acute exacerbation. You look at their kidney function, because all of this is taking place in the kidney primarily. And then you're also looking at their potassium for these reasons. Beta blockers we talked about in pretty great detail in the last video, so I won't go into too much detail, but just remember here that, carvedilol is not a specific beta blocker, but this is also frequently used. These are both used to kind of help with the remodeling. Now, let's just say that a patient comes in and they're in an acute exacerbation in a board question, and their ejection fraction is like 15%. Do you want to give them a beta blocker? Probably not. Remember, what beta blockers are going to do is they're going to slow the heart rate. They're going to decrease contractility. You don't want to decrease contractility in an acute exacerbation if the ejection fraction is low. Okay, so that's the one thing to remember about beta blockers. You can pick an ACE inhibitor in that situation and you'll probably be okay, but you don't want to pick a beta blocker. So beta blockers are more for the long-term use in general, unless the patient can tolerate it. Okay, but usually if the patient is stable, then you put them on a beta blocker because it helps with remodeling of the heart. And we'll talk more about this when we get to the step 2 videos. Sacubitril, we actually talked about this a lot in the RAS videos. The big thing I just want you to remember here is that these Neprilysin inhibitors can increase ANP, BNP, which is great because those are the good guys, but it can also increase angiotensin II levels. And so when you give them this drug, you have to give them the angiotensin II receptor blocker with it so that you're only getting increased levels of ANP and BNP, because again, those are the good guys. Those are the heroes. Angiotensin 2, that's a villain. So if we give them sacubitril, we give them another drug with it, usually valsartan. Okay, loop diuretics. These are very high yield, especially when you get to the wards. You're going to see these all the time. Furosemide is also known as Lasix. You probably have heard of it. It's probably one of the most common drugs prescribed. Essentially, what furosemide does is it acts in the loop of Henle. So it's a loop diuretic. It acts in this area, and there's a transporter here, a sodium potassium chloride transporter. It's in the ascending loop, so it's right around here, and it's going to essentially block those transporters. So what is that going to do? So essentially, by blocking those transporters, it's going to keep the sodium here in the tubule. Okay, it's going to keep the sodium in the tubule. If I keep the sodium in the tubule, I prevent it from going through back into the blood. Then I'm going to have water following salt, and so I'm going to get more fluid. I'm going to get more water that comes through this tubule, right, and gets voided out in the urine. Okay, so I'm going to get fluid off of the patient. That's what these are going to do. They're going to get fluid off because they prevent this sodium from coming back through the transporter. Now, in reality, it's a little bit more complicated than that, but I think just for the sake of step one, that's basically how I would remember this. So again, they're used primarily for fluid retention. If a patient has pulmonary edema, right, you can give them furosemide. Let's just say in a board question, this wasn't really doing the job, and so they gave a patient another medication to try and get the fluid off. That works to potentiate the loop diuretic. That would be classically metolazone, a thiazide diuretic. So usually thiazide diuretics, you'll see like hydrochlorothiazide, that's used for blood pressure. Okay, and we'll talk about that. But what you have to remember here is that there's also, in this distal convoluted tubule, there's also transporters for sodium here. So this sodium, if I gave a patient furosemide, right, and I inhibited the sodium from going back into the blood, some of this sodium could say, hey, look, that's okay. I'm just going to go through this transporter instead. So it won't end up getting to the collecting duct and out in the urine with water, right? So what you can do is you can also inhibit this transporter as well and say, look, now you have nowhere to go, sodium. You're going straight out through the collecting duct now, because not only did you inhibit this transporter, but you inhibited its backup plan up at the top in the distal convoluted tubule. So that's what metolazone does. So if you give metolazone with furosemide, now you're potentiating the diuretic effect. You're making it even stronger. So they get more sodium excreted out in the urine, which means there's more water. There's more diuresis going out in the urine, which is great if somebody's completely fluid overloaded, right? All right, finally, we have digoxin on here. And we're going to go through this mechanism of action in more detail, and I've talked about this a few times in the other videos. But again, the general concept here is you're inhibiting the sodium-potassium ATPase. Okay, so if I just had a cell here, let's just draw a cell here, okay? And so let's just say that I have a sodium-potassium ATPase. So what does that mean? That means normally sodium gets pumped out of the cell and potassium gets pumped in the cell, right? This is active transport. They're going the opposite direction of their gradient. And it does this for ATP, right? And so this is the concept with the transporter. So what digoxin does is digoxin actually inhibits this. So digoxin is going to inhibit this transporter. So how does that affect the cardiac myocyte? Well, look, if I inhibit this transporter, now my sodium cannot get out. So my sodium is going to sit in the cell. Okay, so it's going to get high levels of sodium. So my body says, okay, don't worry about it. I can get that sodium out. And it does that through an additional transporter. It says, okay, here's our backup plan. We're going to get this sodium out, but I have to maintain my ion balance, so I'm going to bring calcium into the cell. Okay, so it's going to bring calcium in for sodium. So then what happens, right? So now I have this buildup of calcium. I'm just kind of trading one for the other. But this is what digoxin primarily does. It causes this increase in intracellular calcium. Remember, this calcium in ventricular myocytes is going to cause increased contractility. Right? It's going to cause increased contractility. And so you might be saying, okay, well, how does that help heart failure? Remember, if you have systolic heart failure, you have a low ejection fraction, you can't contract very well. So if I increase contractility, I can bring up my ejection fraction, and that's what digoxin is doing. Remember, digoxin also has parasympathetic function, right? It can increase vagal activity to nodal cells, specifically the AV node. Okay, so it can slow things down a little bit, potentially put this patient at risk for an AV block if this was toxic, right? And we already said here, increases intracellular calcium in ventricular myocytes. Great for a patient with systolic heart failure, right? Now remember your classic toxicity for digoxin. Disturbed color perception is big, particularly a yellow tint. A yellow tint is usually their way of kind of telling you this patient might have a digoxin toxicity, and usually they'll have some GI symptoms, and it can definitely lead to arrhythmias for the reasons we just mentioned here, AV blocks as well. If a patient, remember we said patients that have heart failure, usually their aldosterone is going to be quite high, right? Because of the RAS system activation and the vicious cycle that they're going to be going through. So their potassium level is going to be low. Now you can see that digoxin inhibits this transporter. Okay, so the potassium levels in the blood in general, when you give digoxin, they should go up a little bit, right? You could get a little bit of hyperkalemia. But digoxin's affinity for this transporter is actually going to go up if the patient has hypokalemia, because the digoxin will then act to balance out that hypokalemia. So my point is, if a patient has hypokalemia in a board question, they're more likely to end up with a digoxin toxicity. Just something to keep in mind. And this is also true if the patient has renal failure. If it's an elderly patient that's getting digoxin and they have a higher creatinine than you would expect, watch out for digoxin toxicity because the digoxin is renally cleared. Okay, so just keep that in mind. The last thing I want to say about all of this that tends to come up, this used to be like a step 2 thing, but it comes up more and more on step 1 now, is which one of these drugs actually improves survival versus not improving survival. You might think, well, don't they all improve survival? You'd actually be surprised to hear that pretty much everything above this line improves survival. Okay, so pretty much everything here, the ACE inhibitors, the ARBs, the mineralocorticoid receptor antagonists, beta blockers, right? The Neprilysin inhibitors, these all are going to improve survival, improve mortality when a patient is on it. But studies actually show that loop diuretics, for example, digoxin, for example, they actually don't improve survival, even though they improve morbidity, right? Morbidity is kind of like the disease state, but mortality is the survival. So loop diuretics and digoxin can improve the symptoms of the patient, decrease the rate of hospitalizations, but they don't actually improve survival. So that's something important to remember. Used to be a major step 2 thing, and it still is, but it's also coming up more and more in step 1, so just be aware of that.